So I'll be talking about a mechanistic link between obesity, diabetes and CVD, and then I'll be talking about the effects of weight loss. Now, what it is common knowledge for us that actually when BMI increases, the risk for type 2 diabetes increases. But when the BMI is increasing within the normal weight range, for example, BMI is moving from 21, 22, 23, the risk for diabetes is increasing very slightly. Once a person becomes overweight and becomes obese, the risk of diabetes increases very fast actually. For every unit increase in BMI, there will be a 1.5% increased chance of developing diabetes. This is better represented by this diagram actually. So good afternoon everyone. So I'll be talking about the clinical benefits of weight loss. One minute, there's something come up here. So this is the post-lunch session. So anybody who wants to sleep, please sleep, no problem. Just don't snore very loudly, that's all. So I am the organizing secretary of Endocrine Society of India, which is going to be held in Hyderabad this year. So we require your blessings to make sure that the conference actually gets held. Please block your dates, and if anybody is interested, please come also. We'll be ready to host you. So I'll be talking about a mechanistic link between obesity, diabetes and CVD, and then I'll be talking about the effects of weight loss. Now, what it is common knowledge for us that actually when BMI increases, the risk for type 2 diabetes increases. But when the BMI is increasing within the normal weight range, for example, BMI is moving from 21, 22, 23, the risk for diabetes is increasing very slightly. Once a person becomes overweight and becomes obese, the risk of diabetes increases very fast actually. For every unit increase in BMI, there will be a 1.5% increased chance of developing diabetes. This is better represented by this diagram actually. So if you can see, if you assume that the relative risk of developing type 2 diabetes is only 1 at a BMI of less than 22, up to 25 you see the relative risk is not increasing much. But after 25, it is suddenly exponentially increasing, so much so that a person who has a BMI of above 35 has 93 times the chance of developing diabetes as compared to a person who's having a low BMI. Obesity, pre-diabetes and type 2 diabetes are nothing but just one disease continuum. So whenever a person is having obesity, you can see that here. So you can see that what's happening is slowly the insulin resistance is developing. Insulin resistance is causing worsening of the beta cell function. Muscle cells are becoming more and more susceptible for insulin resistance, and fatty liver is also developing. Once the person is moving from insulin resistance to pre-diabetes, it's the beta cell compensation that occurs. Beta cell hypersecretion will occur. There will be increased insulin secretion that will be occurring. And once the person moves into diabetes, the beta cell failure will occur and there will be increase in blood glucose. So obesity precedes pre-diabetes. Pre-diabetes will precede type 2 diabetes. It's just one continuum. But how can fat cells, so we are talking about deposition of fat in the subcutaneous tissue, in the visceral fat, how can it cause diabetes? Just because fat is there over there, how does the blood sugar increase? How does the cardiovascular disease risk increase? This is all because that when the adipocytes become from lean adipocytes to hypertrophic adipocytes, remember adipocytes secrete a lot of cytokines. They secrete a lot of inflammatory cytokines, and this inflammatory cytokines is going to all the areas of the body, especially the endothelium, damaging the endothelium and causing atherosclerosis. It causes altered liver metabolism, which leads to CVD and type 2 diabetes, reduces the insulin uptake at the level of muscle, and also beta cell secretion goes down. The lifestyle risk of incident CVD for different BMI categories is such that if you are in the normal BMI, you don't die. If you are high BMI, you will die faster. So that's what this entire slide shows, that the higher the BMI, the higher the risk of mortality as time passes by. Now, how does weight loss actually affect all these factors? That is what we are going to discuss. So goals and benefits of effective obesity management is number one, to achieve weight loss. So achieving weight loss might not be very difficult. You might have a very, very motivated patient who's doing some intermittent fasting or doing some keto diet or taking some medicines and losing weight. The second part is the most important one. After losing weight, to maintain that lost weight becomes the most difficult part. And if you are able to maintain that lost weight and mitigate the risk of diabetes, reduce the cardiovascular risk, reduce the functional impairment, and improvement quality of life, then only you are actually providing some clinically meaningful benefits. So for the first time, the ADA guidelines in 2023, they said now how we should approach a person who has diabetes. So initially, the ADA guidelines used to say, look at the HbA1c and treat the HbA1c. But nowadays, ADA guidelines says, don't look at HbA1c, please look at the weight of the patient also. Please look at the cardiovascular risk that the patient is having, and please find out if the patient has associated comorbidities, and then only decide what to do. And to be very frank, it is for the last 2 to 3 years that even we endocrinologists who are meeting people with diabetes for the first time in the OPD are now talking about weight loss as one target. So we used to always tell, keep your HbA1c below 7, keep your BP below 140 by 90, keep your LDL below 100. We used to never talk about the weight that much. We used to say, do exercise, like that we used to tell. But now we have started talking about weight as an important tool for managing diabetes, and that's what the ADA guideline also says. They also talk about giving good cardiovascular risk management. For every patient with diabetes, don't concentrate only on the blood glucose, but also concentrate on the weight, smoking, BP, lipids, everything you need to concentrate. Then only you're giving holistic care to the patient. How does weight reduction help in the management of type 2 diabetes? Weight reduction, as I said, will improve the insulin sensitivity and preserve the beta cell function. But at least 5% weight loss should occur. Then only the clinically meaningful benefits occur. And for every kg of weight that you lose, you would actually reduce the HbA1c by 0.1. These are the studies which show what are the evidence of benefits of weight loss. So diabetes prevention, so a person who has entered into pre-diabetic stage, we have studies like the Ducking study. The Ducking study says that if you lose weight, the prevalence of, the incidence of developing diabetes drops by up to 51%. And even after 20 years, if you have lost weight, you're actually preventing from entering into diabetes. The Finnish diabetes prevention study and the DPPOS study, they all say that only if you lose weight, the chances of moving from pre-diabetes to diabetes lessens significantly. There is one trial called as the direct trial. Direct trial is people who already have an HbA1c of above 6.5, are they able to reverse the diabetes by good weight loss? And they said by good lifestyle intervention, you can reverse the diabetes and become medicine-free also within 1 year only. So this is 1 year data of direct, okay? So if you lose a good amount of weight, you can actually go back from taking medications for diabetes to not taking medicines. But in people with diabetes, to make them lose weight, it's much more difficult. Why? Because in advanced cases of diabetes, you know, they will be sedentary because of neuropathy, foot ulcers, heart disease. In the early cases of diabetes, patients have lost weight because they have high blood sugar. And you suddenly control the blood sugar, they'll end up gaining weight actually. Glucosuria will go down. There are medications in diabetes that cause weight gain, insulin, sulfonylureas, thiazolidinediones. And a patient who is worried about hypoglycemia will keep snacking intermittently, and therefore it becomes very difficult for them to lose weight. What are the weight loss medications and what are their effects on the HbA1c levels? So in India, remember, there are only 2 medicines that are approved for weight loss, and one of them is not even available. Okay, so one is Orlistat, and the other is semaglutide 2.4. Although it is approved in India, it is still not available in India because it has become such a popular drug in the US that US is using up all the semaglutide that's available. It's not yet reaching India actually. But it's approved, so the DCJ is approved. So once it does come to India, many more people will benefit. There are certain other drugs also which are now going to come in, that is the appetite suppressing drugs like naltrexone, bupropion, phentermine and topiramate. They all cause significant amount of weight loss. But the ones, the liraglutide and the semaglutide, as we know, they are not only weight reducing agents, they also help in the pathophysiology of type 2 diabetes itself. And the prevalence of the reduction of HbA1c is much more with these agents as compared to Orlistat and the other drugs. So this slide shows the same thing. People with diabetes, they find it much more difficult to lose weight as compared to those who don't have diabetes, irrespective of whatever agent they are using. Among all the agents, it is semaglutide, which is the most strongest molecule which is going to cause weight loss. And I said it's already approved in India, so we are going to discuss a little bit about that now. This is the step 2 trial, that is weight management in type 2 diabetes. So, I was actually selected as one of the investigators for this trial. When I went for the investigator meeting and came back, the management in the hospital of my hospital changed completely. So ethical committee was not there only when I came back. And then I said, I unfortunately could not take part in this trial after that. But this trial had a very nice way of doing it. So they compared placebo or semaglutide 1 mg or semaglutide 2.4 mg, and they wanted to find out, especially in patients with type 2 diabetes with age greater than 18 years and on 1 or 2 oral antidiabetics, what is happening. It was seen very clearly that with semaglutide, you are able to lose weight very nicely, and 2.4 mg of semaglutide, remember, this is a trial which went on for 68 weeks, and still the patients managed to lose and maintain weight loss of up to 10 kilograms even after 68 weeks, which is an amazing number. HbA1c understood, as I told, semaglutide, the GLP-1 receptor analogs are one of the most potent anti-diabetics. And therefore, those patients who are on 1 mg semaglutide or 2.4 mg semaglutide, they had an HbA1c reduction almost up to minus 1.7 to minus 1.9. But semaglutide 2.4, it showed beautiful results in the composite outcomes. That means people who are able to reduce 10% of their body weight and also have an HbA1c of less than 7 was seen in 45%. And 1 in 4 patients were able to achieve a weight loss of 15% weight loss and having an HbA1c of less than 7. And most of them were actually reducing their diabetes medicines. The HOMA beta and the HOMA IR also significantly improved as the patient lost weight and were using semaglutide. With semaglutide, there was improvement not only in the sugar parameters and weight parameters, systolic BP and diastolic BP was also decreasing. And fasting lipids have also changed to the beneficial part. The HDL cholesterol is increasing and the triglycerides have started decreasing. And therefore, cardiometabolic effects of GLP-1 receptor agonists have expanded. They don't only affect the pancreas. In pancreas, as we know, they cause glucose-dependent insulin secretion and suppression of glucagon. They don't affect only the gastric emptying, but they affect in the brain to reduce the satiety. To improve the satiety, to increase the satiety. In liver, they reduce fatty liver. In the heart, they reduce the cardiometabolic risk. And in the kidneys, they increase the natriuresis and BP improves. Therefore, all the studies that have been done with GLP-1 receptor agonists, especially semaglutide, that molecule which we are talking, they are shown not only to control the blood sugar, but they are shown to be intensively protective for the heart, for the kidney, and for the liver as well. And stroke also is reduced quite a bit in those patients who use GLP-1 receptor agonists. To summarize, obesity, it's a complex multifactorial disease. It affects 2 crore adults in India, and obesity-related systemic inflammation will increase type 2 diabetes and cardiovascular disease. GLP-1 receptor agonist helps in reducing the HbA1c. It might help in diabetes remission. It reduces BP, it improves lipids, it improves quality of life, decreases sleep apnea, improves pain, renal protection, and improved NAFLD and NASH. Therefore, making this GLP-1 space a very interesting space. And yes, cost is definitely a concern. For most patients who afford it, they can have this myriad of benefits with these particular agents. So with that, I think I'll conclude and we'll stop it here. Thank you. Thanks a lot.